Start. On behalf of Indian Medical Association Headquarters, we welcome you to this digital IMA project of continuing medical education all over the country. Today we are going to talk about vector-borne diseases. And I'm Dr. V.K. Monga. On my left is Dr. Aggarwal. He is the Director of National Vector-Borne Disease Control Program of the country. On his left is Dr. P.K. Sen. He is Additional Director in the same institute. On my right is Dr. Ashutosh Biswas. He is Professor, Department of Medicine, All India Institute of Medical Sciences, New Delhi. And to his right is Dr. Kalpana. She is Joint Director in National Vector-Borne Disease Control Program. Friends, we'll have question answer session with all my panelists. And in case you have any questions, you can SMS them. You cannot ask them directly to us, but you can SMS them on my phone number. Number is 9810118256. I repeat, 9810118256. So you are welcome to give us your queries and anything you want the panelists to answer. Thank you. Friends, vector-borne disease is a more or less a global problem. It's a major public health problem in the country. And over the years, we have seen the rise of malaria, the rise of dengue, sometimes there is chikungunya, there is Japanese encephalitis also, which is there in almost all parts of the country. And our panelists are really senior persons. They are very senior professionals who can answer all your questions, and we can take them one by one. First, I think because of the main issue remains nowadays with the onset of winters and everything is dengue. And dengue always makes a lot of hue and cry all over the country because of its mortality, because of the need for platelets, because of hospitalization, because of public health issues also. So today we'll first talk about the disease as such, how does it spread, and then we'll talk about its treatment, prevention and other aspects of it. We'll start with Dr. Aggarwal as to what is the pattern of the disease, how does it, how does a person get it, and what are the issues involved in the prevention as such from mosquito bite and others. Dr. Aggarwal, please.
Thank you, Dr. Moga. At the outset, thanks to IMA for organizing this CME on dengue, which is very timely. As you know, all throughout the country, we have been getting reports of dengue cases, and in particular, I would like to talk about what is happening in Delhi and what is happening in southern states and the far eastern states like Arunachal Pradesh, from where we got the information of upsurge of dengue cases. This year, we were expecting that there would be upsurge of dengue cases. Dengue, as you know, is transmitted disease. Aedes is the name of the mosquito which transmit, and it's a day biter. And we see trans-ovarian transmission in dengue, which is different than what we see in malaria. And there is no vaccine and there is no specific drug. That is why for dengue, prevention is the most important component. And Dr. Moga has very rightly said that we need to understand that what we need to do as far as prevention is concerned. Now, in prevention, most important thing is that source reduction, we call it, that why should we allow Aedes to breed and to grow. Breeding of Aedes usually occurs in the containers which are available inside the houses or in the periphery of the houses, maybe in the corridors or in the rooftop and nearby places. And these are usually very small containers, maybe of the size of the Bisleri bottle cap. If this Bisleri bottle cap remains like this and water accumulates, this water amount is good enough for laying of the eggs of the Aedes, and then it turns into larvae and pupae, and then comes out in form of adult. And once mosquito is infected, then that mosquito remains infected not only throughout its life, but the new progeny also remains infected. That is why when it comes down to prevention, it's not only drying or emptying of these containers, scrubbing of these containers is also very, very important. And once we allow the transmission to take place, then there are certain issues on which we'll be discussing more. But I would like to mention that for diagnosis purposes, we have two type of test system nowadays
So in
available.
this, I think when you talk about it, you mean that killing of mosquito is not a real prevention. Stopping its genesis,
That's
becoming a larva into adults, that should be the motive of a preventive system.
That's very right. That's very right. That we should not allow, number one, the breeding to take place.
That's right. That's right, sir.
That's very, very important.
Sure.
And that is why this issue of asking for fogging means in these days when dengue transmission starts, when dengue cases start reporting, then many of us think that fogging is the answer. Fogging is not the answer. Fogging is recommended only in a very specific situation where we have large number of cases and large density of mosquitoes are present. Only in those areas fogging is recommended as per Government of India guideline. But otherwise, prevention for prevention, the source reduction and not allowing Aedes mosquito to breed is the most important thing.
Dr. Kalpana, how do you explain that around 60 to 70% of our dengue patients are either school children or who go to offices? Do you think people are getting more of these infections in their schools or in their workplaces?
Yes, these days we are seeing that most of the cases are coming from this age group because Aedes mosquito is a day biter, and when people are out for their office or the children are in the school, during that time only the mosquitoes are very active. And moreover, we are serving these areas and we are finding that Aedes breeding is taking place. This is very intensively in the offices, in the schools. Even in Delhi also, we have surveyed we have one central cross-checking organization. They have been visiting the schools, offices and all the premises has been surveyed. And many of the schools, they are having very high density of Aedes mosquito, and the offices are also showing the same very high density. And this is the reason we are getting very large number of cases from these from
That's right.
yes, from office going people or the school children. That is the reason. We think that only at our residence only Aedes mosquitoes are breeding. It's not like that. Aedes can breed anywhere and everywhere in the containers. So we need to really take care of not only our houses and the workplaces as well, and the schools.
But Dr. Sen, this you can collaborate like this, that in my house I am taking care of my places, my cooler and everything. But in an office or in a school, there is nobody to look after you. It's nobody's baby. So everything keeps breeding. People are not monitoring the things. And do you suggest any measures whereby there can be better monitoring of these school premises and offices and other places? And I'm told that it may be just below your table also at this time.
Yeah.
So what are your guidelines for this?
Yeah, basically this is an important concern for prevention and control of breeding basically. So in different meetings it has been stressed upon that for the premises of say office or hospital or residential premises also, there should be some persons should be identified who should be accountable for looking for monitoring of these breeding places. This is very important. Actually, for this, people's involvement is very much important, and different departments are actually involved. Say in Delhi, for government premises, say CPWD, engineers who are looking after some particular premise. This is also, they must have some accountability for that, so that this breeding of mosquitoes can be clear, can be monitored in that respect. So identification of some persons who will be accountable for, say, residential premises, from office premises, for hospitals, for educational institutes like, say, some important schools or other IITs or medical colleges. So someone will have to be accountable for that, so that this can be checked out. This is
That's right, that's right. But because every year we find that some VIP players, training starts the first. Even the president of India, the house has, we have found breeding at many places recently. But I think now we come to our friend from All India Institute of Medical Sciences. He's a senior, very senior clinician. Dr. Biswas, AIMS is very notorious for this. When I was the chairman of health in Municipal Corporation for 5 years, every year we used to know that AIMS, first case comes from AIMS and last case also comes from AIMS. And now we'll not talk about it, but we'll talk more about the clinical manifestation, how a patient manifests itself, number one, and how do we diagnose it also. What are the latest guidelines, what are the latest diagnostic procedures that we should adopt in our day-to-day practice? Dr. Vishal.
Yeah, this is Dr. Monga. This is a very important, I think, area to understand by each and every doctor. They see the cases, and those who are involved in management diagnosis. Now, for diagnosis of the dengue cases, that we have clinical symptoms. Basically, whether you have diagnostic tools for the microbiological setup or microbiological diagnostic facilities, whether you have in your hospital or not, is sometimes immaterial. But if you have knowledge of clinical features, and based on that, sometimes you can diagnose also. The most important clinical features that we know is divided into 3 groups of this recently guideline. The diagnosis clinically based on 3 categories: mild dengue, moderate dengue, and severe dengue. So this is simplified and to understand by the doctors and clinicians what is mild dengue. Mild dengue means that fever that patient is having during, especially during the outbreak and monsoon season. So if anybody having less than 5 days of fever and with myalgia, arthralgia, high grade fever, and slightly having GI symptoms, maybe vomiting, pain abdomen, maybe loose motion, diarrhea, we should suspect first is hopefully is a dengue. And at the same time, we should also understand that this is a vector-borne disease. Other malaria and other chikungunya are too comes as a differential diagnosis. And not only that, waterborne disease, typhoid also comes. So naturally, you need to closely match with these symptoms, and sometimes it's difficult to exclude malaria, typhoid clinically. But yes, if the classical signs, sometimes if the rashes are there, some bleeding sign symptoms there, and some danger signs, some warning signs are also there. If patient having warning signs, then we group them as a moderate dengue fever. So those patients having fever only without warning signs, without any danger sign, we call this mild. If danger signs are the GI symptoms, vomiting, diarrhea, mild hypertension, headache, myalgia, arthralgia, this all comes under symptomatic. We call this is a moderate dengue. But another class of group of people that having pregnancy, having dengue. But at this moment, when the patient having fever, a pregnant lady may not have immediately any complication, but it has been seen that they may go for develop more complications. So pregnancy and dengue chances of developing complications are more, like hypertension patient, diabetic patient, those are immunocompromised, and tuberculosis patient on ART. So different other comorbid illness patient having dengue infections, they are also grouped as a moderate dengue because it has been seen they are likely to develop severe dengue infections. And what is severe dengue?
Yeah.
Severe dengue, again, there are three groups. The one is that, low blood pressure shock. So as we know, in dengue, there is a fluid from intravascular, shifts to extravascular compartment. There's a capillary leaking syndrome, basically affect the endothelial membrane of the vessels. That's why there is a rash and all, bleeding and all, hyperemic skin, bleeding from different sides. And so this is basically dengue is a vasculopathy and coagulopathy. These two things it occurs. Coagulation profiles are impaired, and then vascular endothelial membrane are also affected, like other viral hemorrhagic fevers. So this is all like also Ebola. So it's not that severe, but if due to this process it involves the most of the organs, vital organs, liver, kidney, lungs, brain, this can be affected also. There are many case reports that patient having fulminant hepatic failure, renal failure, and also encephalitis-like syndrome, encephalopathy, and ARDS patient. So different organs are also involved. So which are otherwise also called as EDS, extended dengue syndrome. That's also, it was coined like that. But is a organ involvement is one. Then your cardiac involvement may be also there, and also patient have a shock. These are the group, and sometimes also we see due to dengue infection there may be metabolic derangements, acidosis, alkalosis, dyselectrolytemia, patient having persistent diarrhea, vomiting, so hypokalemia. This can lead to altered sensorium. So these are the patient in initial stage. If we can see any of these, probably they are definitely taken as a severe dengue cases. Now, if you can group at a given point of time that this is mild, moderate, and severe, then it is easy to manage. If I diagnose this as a mild, naturally comes under how to manage a mild case is already there, that the management line moderate with the shock, then naturally fluid therapy, and there are other parameters like one dengue means we talk about the platelet. Most of the people they think, see the platelet how much and all. So this has become, dengue has become like a treatment, nothing but platelet. Everybody runs after platelet, and many hospitals they really, without going into the depth of this, 50,000 go for platelet, 80,000 go for platelet without
So
hemodialysis.
before we come to platelet part,
Yeah.
I was just thinking that I'm a clinician, and a person with fever of 2 days history comes to my clinic. It's a high grade fever, 100, 300 fever.
Right.
Then how would I know, number one, that it may be dengue by any clinical investigations, or how would I know that this may be one case which may be going into severe variety or a complication variety or a hemorrhagic fever or maybe going to shock? Can you, on the day 2 of fever, can you, as a clinician, put your mind into all these things and decide something that what is to be done, whether it is dengue or not, and if it is dengue, is it going to be a severe one or a mild one?
Yeah, always there is a diagnostic dilemma, maybe there in the initial stage, and then if dengue, predicting its severity. This is very important areas. If I can predict after 2 days you are going to develop cardiac shock or hemorrhagic shock, then probably we can take that patient very, set in the ICU and then take care of this patient. But there is no such predicting markers yet. The biochemical markers we don't have. There are few coming up as a research mode, but not as a randomized control trial that we can't say this is definitive biomarkers for prediction of this. There are few that those things are there seen. But yes, few clinical signs are there. If you see, the first is the initial, a patient second two days strep fever, high grade fever, how we will know whether it is a dengue or not? First is the a seasonal that we don't get in the winter. If you come patient with high grade fever, naturally we don't think this is a dengue. So it has to be naturally in Delhi or geographical area where outbreaks are there in the monsoon. So during monsoon, where there is a incidence, prevalence of the cases are rising, then naturally doctors are warned by the cases are coming. So febrile incidence of the cases of dengue, then you can suspect this one is the background information. Second is signs. There may be patient may be that we know 70 to 80% sometimes dengue are asymptomatic. We never know. Some mild fever comes and then goes. Subclinical, it goes. So it's very difficult. Those who are coming 20-30% symptomatic with the fever, then definitely rash is the one important thing. This is a diagnostic almost. The viral hemorrhagic fever. If you find any rash on the body, skin, that is one you should look for. The congestion, the conjunctival congestion is a very important thing. That sometimes we find there is redness of the eyes. So this is one. And here is the necklace area with sometimes hyperemic skin. Now those are signs. If you press and you get a impression on that when there is, if you put the stethoscope on the skin, so you get a impression because of the delayed feeling defect, the delay in capillary feeling. So that gets into due to the maybe patient is in hypotension or shock, and there's a capillary also leakage. The edema is also there. So feeling delayed. That is one
What
important
about
thing. And other signs
most of the labs are doing NS1 tests, rapid tests?
yes, diagnostic
In
test.
at least in practice, I mean, we find that everybody brings a report of NS1. How good or bad? I mean,
Yes,
it is.
Dr. Dhariwal already has highlighted about the RDT test. The sensitivity and specificity of these RDTs are very poor. So it is maybe 50%, 60% or so. It varies from company to company, little bit, maybe more or less. So that is the reason the RDT should not be a confirmatory test.
Okay.
So it is always a ELISA test. By ELISA, it is positive naturally. But yes, now sometimes there is no facilities. Now RDT is the easy way to diagnose and to exclude other differentials like malaria, typhoid. At least if you do get the positive RDT, dengue, so you are at the same time excluding typhoid, you are excluding malaria.
There can be combination also.
Yeah, there may be 2-3%.
Yeah.
One, two, not very common. So it really it's not confirming the diagnosis, but it can help for the managing the clinicians. But for reporting, yes, we need a confirmation diagnosis, and RDT definitely sensitivity, specificity poor.
Would you like to add something onto this?
See, as far as diagnosis is concerned, then from government side, I would like to inform all our fellow practitioners that use that facility. Government of India through state government is providing free of cost this diagnostic facility, and this diagnostic facility is available in almost all the district headquarters where dengue is a problem. And for diagnosis, two type of tests are available, as Dr. Moga said, NS1, which has to be done in first 5 days of illness, and this is basically a antigen based system where antigen is demonstrated, and that's positive in first 5 days of illness. After 5 days, once antibodies are there in the blood, then we have IgM based again ELISA IgM based kits. So both the kits are available at these identified places, and my request would be to use this facility. And since this is available free of cost, and to share a professional advice, as a professional, public health professional, I feel that diagnosis, you would agree, doesn't make the difference in management. Means
Yes,
if
sir.
clinically we are suspecting dengue, and when we know in the city or in a particular area dengue transmission is taking place, then we should not unnecessary ask patient to go for the investigation and advice can be
Yes,
given for the management.
this matters, you know.
But yes,
Especially in practice, everybody comes. Everybody on day one they'll come. Sir, dengue तो नहीं हो गया मुझे. Yeah, it's a common thing. And Dr. Kalpana, I mean, we have been talking about this now. Is there any preventive vaccine available that India has developed or anywhere in the world?
Yeah, vaccines have been developed by Sanofi Pasteur. The clinical trial they have finished in some Latin American countries and in some South Asian countries, and in India they are yet to start the clinical trial. It is phase 3 trial they have finished, and this vaccine shows that it is almost providing this protection against all these 4 serotypes, but this serotype 2, which is known to be more virulent, that protection is bit less. And one more observation has come out from this Latin American study, that it only broaden that earlier immunity, not that someone who have not exposed totally, that it will provide the protection. So now the question comes that in India, suppose we bring the vaccine here, all these 4 serotypes are prevalent, and we know if someone is having type 2, which is having more virulence, so complications will be more. But if the present vaccine is not providing that much of protection against this virulent serotype, then it won't be of any public health importance. So that's why that manufacturer, they are working on it, how to improve this protection, this capacity of this vaccine. Then in India also, I think they have to carry out the phase 3 trial if it has to be come to in India also. In none of the countries across the globe now they have started, since this phase 3 trial have recently they finished.
Okay. And Dr. Sen, she is talking about 4 types of dengue fever, 4 types of the serotypes. I'm told that there is another type, 5th one coming up. I mean, how would you rate that? How would you react to it?
Yeah, there is one new type 5, serotype 5, that has been emerged in some of the areas, particularly in Malaysian range, but that is not quite prevalent in other parts. In India in particular, actually these 4 serotypes are prevalent, and in different places, particularly in Delhi, these 4 serotypes are prevalent, but many of the times it gets changed. So sometimes this predominant is 2, sometimes it is 3, but all the 4 serotypes are prevalent in Delhi, in other parts also.
So no danger of type 5 serotype.
But that has not been attributed that this is more dangerous compared to type 2. So that is yet to be established whether this type 5 is to be.
That's great. That's great. Now, sir, we again come to your side. Sometimes people say if it is dengue test positive, admit kar lo ye mujhe. Everybody wants admission. Nobody wants to take a risk. And then there are some guidelines by the Government of India Health Department when to admit a patient and how to manage a patient once a patient is admitted. These are the 2 things I think you will be the best person to tell us.
Yeah, so what are the admission criteria in a
Sure.
dengue? So when patient comes, is it indicated that admission, that whether it is a symptomatic or is a biochemical parameters indicating you to admit? There are symptomatically, yes, some signs are there in the patient having organ involvement, which we clinically say is a severe dengue. That means the organ, any organ, significant organ involvement. And to understand that organ involvement, you need to know the symptoms and also biochemical test. Suppose if I had to say this patient having dengue fever with a liver failure, now pain abdomen, so naturally we have to go for SGOT-PT to see how much it is high. So if it is 400, 500, naturally it is going to have an impact on liver, and liver, I must want to admit that patient to see and to care. Like this other respiratory system, hypotension, patient having any electrical abnormality, and definitely sometimes we say if the platelet count is too low, maybe around 20,000 and 10,000, that's the indication for admission and to manage accordingly. And in between that, patient having high risk group, dengue with high risk group, like a pregnancy patient and other metabolic abnormality, comorbid condition, old age patient. So I'd like to observe and see, because this patient cannot be sent home and again danger coming back and going.
Sure,
So in
sure.
that patient. So and mild cases we would like not be admitting, because then probably this warning sign again is warrant for admission. But really all the patient having warning signs are not indicated for admission and managing. We can counsel them that you go home, you take this are the advice, follow them. If anything you have, then come us, we'll admit. So not blanket the dengue means you admit the patient, not that low platelet you admit the patient.
Okay, okay. And then, because I mean, if you recall, first epidemic in 1996 in Delhi, 10,000 plus people,
Yes.
400 plus deaths.
Yes, yes.
And now the death, the mortality has come down to even less than a quarter of a percentage.
Yeah.
And in these things, I think the plasma expanders have played a major role against vis-a-vis the role of platelets.
Mm-hmm.
And how would you, tell our general practitioners in remote areas that plasma expanders, what type of plasma expanders, or what is the treatment to be given in a simple case of dengue who is admitted in a hospital?
Yeah, in 1996, I know I was really at the time was not much of exposed
People
to
did not
this.
know much about it, yeah.
Before that,
Yeah.
and when the patient was pouring in the AIMS, I didn't know much about. So a lot of death I witnessed in front of me, because the management was not really known to us how
Yeah,
we should.
yeah.
And over time, really 10-15 years gone, so we understood the pathogenesis, pathophysiology of the dengue now. A lot of things we knew about that. So we are upgraded now in the management little bit, how the virus is playing inside our body and causing nuisance and then damage to the. So at this moment, the management that about plasma expander. So that is required only patient is going into shock.
Okay.
If the patient is not having any hypotension and shock, then we should not go for any kind of your plasma expander or anything. We can go for a normal IV fluid only, because in this patient there is a hemoconcentration already. So we need to go for very important parameters is the measurement of hematocrit.
That's right.
Hemoconcentration, because that tells you, and if the hemoconcentration is high, more likely to cause damage to the lot of organ, and then probably further complication, because it causes your hypotension, and then organ blood perfusion is diminished, and then hypoxic damage, hypocircular, the low capillary, and the pressure, and then probably damaging on. And second is that probably leakage. So the more important management, that there is no specific management in dengue, because we don't have any antiviral drugs.
Yeah.
So only the management when there is a fever, there are two things. Fever is the paracetamol that we should give. That is only the safest drug. No other things that we should give really, are all other areas can have an antiplatelet effect and further cause damage to the platelet. Increases the bleeding tendency in this case, as the dengue has the bleeding tendency. So only paracetamol when it is required. If not, probably we can give 6 hourly, 500, and sometimes 1 gram also, injectable also, sometimes it is not decreasing. And second is there was a cold sponging.
Good. No antibiotics.
No antipyretic, nothing. So cold
No
sponge.
antibiotics also.
No
Will help in
antibiotic.
this case.
There is no
Good.
antibiotics should be used, because it is not infective a cause. And then close monitoring about the hemoconcentration at the platelet.
Correct. And sir, I'll request you to add on in case you want to add on something to this. And number two, I would like you to highlight that second episode of dengue is much more dangerous, people say. And how is it dangerous, and how we can talk about it or think about it and treat about it. The
Let
second
me-
episode, yeah.
Let me take first question,
Sure.
because that is important
Correct.
for us in the present situation. We have come out with our new guidelines which are available on our website also, and the name of the website is www.nvbdcp.gov.in, and it's available on the home page. And I would like to refer on the annexer 1, which is a ready reckoner, means for any uh, general practitioner, this piece of information, just two pieces of information, are very important. It summarizes many questions which comes to our mind, that when patient has to be admitted, what has to be done. And I recall Dr. Aggarwal's, he has always been talking of rule of 20.
Yeah.
So that's very very important, that pulse pressure has to be in that range, hematocrit also has to be monitored, and all those clinical aspects are very very important. And now less emphasis on platelet, as Dr. Vishwas has explained the logic behind it also. So that is the first thing I would like to mention, and I would like to clear all the air, and I would like to appeal as a medical professional also to all our fellow colleagues, that we should give the scientific advice and we should believe in ethics practice, which has been taken up under IMA as a special campaign, that we should be very particular in following the scientific based guidelines. We should not unnecessarily put pressure for platelet investigation, for platelet count, for platelet transfusion, etc., etc., and kindly follow all the details are available in these guidelines. Now, addressing to second question, that what happens when patient gets second infection. This is no doubt a hypothesis, and the earlier used terms, the dengue hemorrhagic fever or dengue shock syndrome, there was a hypothesis that if we get second time infection, then there is more possibility of having coagulopathy or vascular leakage more.
Yeah, sure.
And definitely means that is the observation made at several places also, but there is no documentation to this effect. This still remains a hypothesis, and like Dr. Sen has informed, that there are 4 types of viruses, and it has been observed that DEN 1 and DEN 3 are relatively milder in nature. We don't see much of vascular leakage or hemorrhagic, or in new terminology, severe manifestation. Severe manifestations we see with more with DEN 2 and DEN 4. That is the observation.
That is the basic. Sir, आपकी तैयार वीडियो हैं? We'll play a 2-minute video from Dr. K.K. Aggarwal, Honorary Secretary General of IMA, who has not been able to make it today here. And he has a message for all of us. Let's see that video from Dr. K.K. Aggarwal. So in the meantime, as he puts it on, we will go over to malaria, because malaria is rampant in most parts of the country. And because they'll be able to tell us better, 1951 onwards, the journey of malaria has been topsy-turvy, going up and cases coming down, lakhs and lakhs of people were dying sometime. But I think now, once we are talking in the capital, we are talking to doctors all over the country, we should know the upsurge of falciparum and the complications in various parts of the country, especially the eastern parts of the country, where falciparum is really rampant, and people are sometimes not knowing what medicine to be given and how to take care of these type of patients. In the meantime, the things are ready. I'll request that person to put it on.
Greetings from Indian Medical Association. I'm Dr. Aggarwal, Honorary Secretary. Welcome to our weekly digital IMA Webcast. And the topic for today is vector-borne diseases with special reference to dengue fever. Today's session will be moderated by Dr. V.K. Monga, with large experience of dengue when he was the counselor in MCD and chairman of the health committee. With that, we will have Dr. Aggarwal and his team who will be answering all your questions, interacting with all of you for the next 1 hour on a subject of importance. I remember when I was in MBBS, we have never heard of dengue. In the last 2 decades, we have seen dengue as a havoc. We have learned a lot. We have learned and managed platelet mania, but today we know that platelet is only a mania. We have stopped doing platelet. Platelet is only an indicator of an impending plasma leakage. More and more importance is being given today to plasma leakage, to PCV, to hematocrit, to concentration of blood than on platelets. So take away the platelet mania and don't bother about platelets. Remember, platelet count can have an error of 40,000. More important is that if a patient has dengue, just manage him with fluids. Look for plasma leakage, that means upper and lower blood pressure difference. If it is less than 20, there is a plasma leakage. If the hematocrit rises by more than 20%, there is a plasma leakage. If the SGOT, SGPT are very high, if the platelet count is less than 1 lakh, chances are patient has plasma leakage. Maintain his blood pressure difference, systolic and diastolic, more than 40 with enough fluids. So fluid resuscitation is more important than platelet resuscitation. Remember the formula of 20, that if the blood pressure falls by more than 20, if the pulse rises more than 20, if the pulse pressure is less than 20, be concerned and give the patient immediately 20 ml of fluid per kg body weight in the first hour to tackle the plasma leakage. Make sure a patient gets enough fluids and he passes urine every 3 hours. No patient of dengue will die. Let's now have an interaction. Dr. Monga in conversation with the experts in dengue, malaria and other vector-borne diseases. Thank you.
So thank you, Dr. KK, for your nice words. In fact, that is what we have been discussing in the last 45 minutes or so. And we have a good panel of our professionals, experienced doctors. We were talking about falciparum malaria. Dr. Kalpana, falciparum malaria is a concern nowadays all over the country. And we'll request you and Dr. to say a few words about the spread of falciparum and the treatment of the falciparum. We'll talk to Dr. Biswas again.
Let me take malaria, because I come from a department which is dealing with malaria in the country.
Yeah.
And definitely it used to be rampant once upon a time, but now in 2015 situation is not that bad.
Okay.
Situation has improved over the period of time. As a country, as a nation, also the efforts being done by Government of India is appreciated at all levels, including World Health Organization. We are able to brought down cases of malaria from 2 million cases as per the government statistics. I agree. There is problem of underreporting. Many of our friends, they want to report, but because of some systemic problem, the numbers which are being conveyed by the practitioners are not part of the present data set. So we are aware about that problem. So the numbers which I am quoting have come down, and it's about 1 million cases and not many deaths. Now, the problem which remains of malaria is in northeastern states where falciparum still remains as high as 80% or in some places 90% of total malaria cases in that region. Elsewhere, particularly I would like to mention western part of the country. May it be Rajasthan, Gujarat, Maharashtra, Karnataka, Kerala, Tamil Nadu, PF is less, falciparum, and it's just the reverse that 70 to 80% cases are because of P. vivax and remaining are P. falciparum. Now, one thing I would like to mention that for the treatment component, now we are very clear based on the data available within the country generated by Indian Council of Medical Research, National Institute of Malaria Research. We have a system of doing susceptibility study over more than 30 cases from different places in the country. And based on that data, we know that for P. vivax, chloroquine is still effective. Chloroquine is the drug of choice, and chloroquine has to be given for 3 days. And P. vivax, because there is hepatic cycle, that is why primaquine is also very, very important. And my request would be to all my friends in practice, kindly ensure that if you are treating a case of P. vivax malaria, then kindly see to it that 14 days primaquine
So
is
primaquine is
given.
not available at most of the places.
Let me again make the things clear, and this issue we have verified. This is being said that it's not available, but it's being produced within the country and it's available in, I can vouch, in all government health facilities. Maybe some of the private practitioners might be finding it difficult to get it because it's available in the market, it's a very cheap drug. So that is why not many industry they find it economically viable to produce it.
Produce and sell in the market.
Otherwise,
Profit is less.
Yeah.
as far as our nation is concerned, we are presently leader in pharma, and primaquine is being manufactured and primaquine is available. If anybody has any observation that they are not finding it, my request would be that on our website there is a feedback, and we would appreciate receiving information about non-availability of primaquine anywhere. This I am making purposely appeal to all colleagues, because now we have taken a decision that, like, we have eradicated polio, guinea worm, smallpox. Similarly, malaria is also fitting in that category, that we have effective drugs and we have seen that it can be eliminated, and that is why Government of India is working on elimination, and in elimination role of primaquine and 14 days radical treatment would become very, very important. As far as P. falciparum is concerned, in P. falciparum nowadays chloroquine is not recommended. Again, my request would be, and very strong appeal, that kindly don't use primaquine when you are treating a case of falciparum malaria. For falciparum malaria, ACT has to be used. ACT means artemisinin based combination therapy, in which the artesunate is the most important chemical, which is a herbal drug and presently imported from China.
Okay.
But recently, our own pharma company has come out with a synthetic formulation of artemisinin, by the name of Synreum. Arteralone is the name of that chemical which is synthesized and is available and is licensed in Indian market also. So ACT has to be given, in which in addition to the artemisinin or artesunate, there would be a partner drug, and partner drug could be sulfadoxine pyrimethamine, could be lumefantrine, could be pipraquine. So these drugs, these combinations are available in the market, and our program, Government of India guidelines, says that ACT with sulfadoxine pyrimethamine has to be used in all the states except northeastern states, where we have observed it to be effective. Only in northeastern states in 2013 we have taken a decision to switch over to lumefantrine as the partner drug, only for the northeastern states. The dose of artemether plus lumefantrine, the ACT for northeastern states, is 1 BD for 3 days. 6 tablets has to be given, and it has to be given with meals. While the ACT SP has to be given first day artesunate 200 milligram and sulfadoxine pyrimethamine on first day. Second day artesunate plus primaquine. In P. falciparum only single day primaquine has to be given,
Correct.
and that is given on second day. Third day only artesunate has to be given. So these guidelines are also 2014 guidelines for diagnosis and treatment of malaria in India is available on our website, where all the details, what has to be done during pregnancy, what has to be done in children, how severe cases has to be managed, all those things are available. And before handing over to Dr. Vishwas, I would like to again say that in severe malaria, our friends are in habit of using only injection artesunate. They infuse and then they forget. That's sort of doing a crime, because I may inform you that artesunate monotherapy is banned. Not only in India, globally, nobody is allowed to use artesunate as monotherapy. And there is a DCGI, Drug Controller General of India, notification also done in 2012, reiterated in 2012. Earlier was 2009 and then reiterated in 2012 that artesunate monotherapy is banned. Not only manufacturing, use also is banned. So my request is, if you are treating any case with injection artesunate, then kindly ensure that they should get complete 3-day treatment of ACT also.
That's right. Great. And only 2 minutes for you, because we are running short of time. We have to talk about chikungunya and Japanese encephalitis also. You can add on to what he has said.
Yeah, I think Dr. Aggarwal has rightly emphasized very important points, almost covered everything regarding the management part. That one is during the management, clinician must remember that it is ACT. Yes, not is it just alone only artemisinin or artesunate. It is a single drug is really banned. But in severe cases, yes, injectable drug that we give, but we don't give the combined therapy later on. So you can add that one that we usually forget. So one is the long-acting drug, one is the short-acting drug, both combined together, that is ACT, to minimize the development of the resistance. So both things should be combined one. Another is that chloroquine that should not be given in falciparum when you are suspecting MPF. Should not try with that. That is one. So
Is that some side effects, or it is, why don't you give it?
Almost resistant. The high
Resistant.
resistance.
That's the only issue. Otherwise, there is no adverse effects or nothing.
That's it.
But if the Vivax there, so one should not try with the ACT. Still, drug of choice is Dr. Aggarwal says the chloroquine. So when Vivax, we first try with the chloroquine, and then if not, probably later on we can switch over to ACT for the Vivax. And then both I think the clinicians are playing important role, should play important role for prevention of this controlling of this epidemic in not using primaquine, because we don't have habit of writing primaquine for 14 days. We give the treatment chloroquine, we just forget. So that habit is not there. Whatever the patient is having, either Vivax or falciparum, primaquine is a must, both for the both. But for falciparum, it is a single dose. On second day, we have to give only one, because it is only the primaquine is only the gametocidal drug. So in case of falciparum, and is hypnozoite in Vivax, requires 14 days to clear it up from the liver cycle.
That's really good. Another 3 minutes for Japanese encephalitis. There are many areas in the country where JE is prevalent, number one. Number two, you can talk about the reservoir, you can talk about the sensitivity of the vaccine, availability of the vaccine, and the effectivity of the vaccine. 3 minutes.
Japanese encephalitis is a problem in some regions of our country, and along with Japanese encephalitis, actually the problem is as a whole acute encephalitic syndrome, and it is prevalent, this acute encephalitic syndrome and Japanese encephalitis as well. It is prevalent in at least 5 states in our country, like Uttar Pradesh is one most important one. Uttar Pradesh, Assam, West Bengal, Bihar and Tamil Nadu. These are the most high burden states regarding acute encephalitic syndrome and also for Japanese encephalitis. And of course, we have the most important tool for prevention of Japanese encephalitis in the sort of vaccine against Japanese encephalitis. And right now, at present, we have 204 endemic districts in the country, which has been identified for vaccination campaign.
As a regular
I'm coming to that. It is in 204 districts who have identified as JE endemic, Japanese encephalitis endemic, where we have the schedule of giving Japanese encephalitis vaccination campaign in children 1 to 15 years of age. This vaccination campaign is actually followed by routine immunization in children, one with 2 doses of vaccine. This vaccine is imported from China. This is SA-1442. It is live attenuated vaccine, and it is given at 9 months of age in children with measles vaccination. This is one, and this is followed by a second dose at 16 to 24 months of age with DPT booster. So this is 2 doses is given under routine immunization. And right at this moment, there are some regions where Japanese encephalitis, which is considered to be a disease mostly amongst children below 15 years of age. It has been observed, particularly in Assam, in West Bengal, that adults also are being affected with Japanese encephalitis. And in Assam particular, nearly 60% of the cases are occurring in adults. And in West Bengal also, there is a substantial proportion of persons who are in adult age group, above 15 years of age. So, Government of India has decided, on the recommendation of National Vector-Borne Disease Control Program, to undertake adult vaccination campaign in some of the high burdened identified districts where Japanese encephalitis vaccination campaign is to be done amongst adults 15 to 65 years of age. And we have taken up this adult vaccination campaign in the state of Assam. These 12 districts have been taken up in Assam for adult JE vaccination.
That's okay, sir. That is understood. But why is mortality so high in these cases?
Mortality, actually, it has come down over the years. What was thought to be about 30% case fatality rate, it has come down to nearly 18% right now.
Okay.
And we do not have specific treatment for Japanese encephalitis. But Government of India has taken a program so as to take this case management one as an important strategy under the program. So in identified 60 high endemic districts, we have taken up this case management as an important component with establishment of pediatric intensive.
We have only 2 minutes left.
Just responding to Dr. Gopal Rai question, that artesunate injection has to be given twice in a day, and if patient recovers and gains the consciousness, then there is no need of going for next injection of artesunate. What I said that injection artesunate has to be followed by complete 3 days treatment with ACT. If it is given for 3 days injection, then also 3 days ACT has to be given. So
And
that is the
1 minute
clarification.
on chikungunya.
Chikungunya is a disease in which we see more of big joint involvement, and important thing which we have observed that in pediatric age group we see recovery without any problem, but higher the age, higher is the problem of residual effect of this joint involvement. As such, there is no treatment. Persons have tried steroids, etc. But the randomized trials has shown that the supportive only symptomatic treatment has to be given.
There is no
for-
mortality also
Yeah.
because of the disease. That's
And
it.
there is no
Like,
mortality.
on chikungunya?
Yeah, I think chikungunya mortality is very less, but there is morbidity. Even after having that, there are a lot of complications. That joint, especially the joint involvements, that lingers.
People
for
have
many-
died because of analgesics and antibiotics.
Yes,
And
lot
instead of the
complications,
disease,
the
that's it.
treatments,
Yeah, yeah.
not per se the disease.
Yeah.
So mortality is very less. So, but the morbidity is that cripples the patient for joint pain and all,
It's
lingers
very,
for many
very,
months
very
and years.
painful, very crippling. In fact, I have seen a few
So
cases.
that management really, there is nothing very specific, but yes, we manage with the various analgesics and steroids sometimes, and then all depending on the severity of the disease.
One point. Just one more point I would like to appeal to all friends that if you are running a nursing home or a hospital, kindly during this time when dengue transmission is going on, see to it that your hospital is free of ADs. Kindly put somebody on job to take care of.
So
elimination of
prevention
this.
is the key, not the
Exactly.
treatment. I mean, treatment is a
Exactly.
different thing.
Exactly.
But I think at the end of the day, we are all wiser by knowing that we should, number one, take care in preventing the spread of the disease by taking care of our own houses, offices, colleges, complexes, every place, number one. And number two, any fever, person should go to the doctor, qualified doctor, take treatment, take his guidance, whatever investigations, and not rush for any admissions or hospitalization or any very, very dramatic medicines as such. Thank you very much. Thank you, Dr. Biswas, Dr. Kalpana, Dr. Sen, and our old friend is the real father of public health in the country. Thank you, sir.
Thank you,
Thank
sir.
you very
Thank
much.